Hello everyone, welcome. Today this is the sixth session of the Pediatric Respiratory Critical Care Series webinar under the aegis of the World Federation of Pediatric Intensive and Critical Care Societies. So it's going to be an exciting one today because this is a new format which we are going to conduct today. We have been doing lectures style in the past 5 sessions, and today we have a debate and a very interesting one because we have some big names who have done a lot of work in HFNC and NIV, and we have been reading their work and following them. So before we start, just a reminder about the World Congress between 26th and 30th September at Melbourne. Do register, and we are closing the registrations this month end. So this Pediatric Respiratory Critical Care Series has been a new initiative of the Education Committee of the WFPICCS since January this year. And we as a team, myself, Dr. Milind Jambagi, Dr. Farhan, Dr. Michael Canary, Dr. Abdul Rahman and Georgina have been working really hard to bring together all the big names in the field of pediatric respiratory critical care, and we are glad that we are getting good feedbacks from all of you, and we acknowledge the various feedbacks, and we are trying to implement them and improvise day by day. So thank you once again for all of you for joining us, and I would like to introduce the first two speakers for today. So we have with us Dr. Andreas Schibler, who has over 30 years of academic work improving the respiratory support methods for children, and to his name he has more than around 180 papers and has contributed to more than 5 medical books. And out of the research, most important one which we all know is the Paris studies, which has improved the respiratory support, helped in improving the respiratory support for children who require oxygen therapy. In the same team we have Dr. Christophe Milési. He is a pediatrician and pediatric intensivist at Montpellier University Hospital, and his research focuses mainly on the non-invasive ventilation, high flow oxygen therapy and bronchiolitis. So in the other team in NIV, I would like to hand over to Dr. Abdul Rahman, my colleague, to take over and introduce the other two faculty.
Thank you, Dr. Miland. So it's gives me an honor to introduce to you Dr. Marti Pons. Dr. Marti Pons' main clinical interest is respiratory care in a critically ill patient and patient requiring long-term mechanical ventilation. His research field focuses on mechanical ventilation, especially non-invasive ventilation. He's published more than 90 studies in multiple journals. In 2015, he published the 3rd edition of the book NIV in Pediatrics, written in collaboration with Dr. Alberto Medina. In 2024, he was co-editor of the book Prolonged and Long-Term Mechanical Ventilation in Children. Next is Dr. Manu Sundaram, is the physician lead for quality and safety within the PICU and assistant professor of clinical pediatrics at Weill Cornell Medicine, Qatar. Dr. Sundaram brings extensive expertise in pediatric critical care medicine, particularly in acute, non-invasive ventilation and long-term ventilatory support for children with complex respiratory needs. So without further ado, we're going to start our debate. Okay, so okay. And here we go. Okay, so I hope it doesn't lead to this.
Sorry, we have the Q&A session at the end. I just wanted to stress upon this, that if you have any questions, please drop them in the chat box. We'll be taking all those questions at the end of the session in our Q&A session.
Thank you, Milan. So please don't forget to post any question comes to you, even if it's related to the cases or related to the question in the chat below. We'll try to ask it to the expert at the end of the session. So this how it's gonna be the debate. The debate has 4 questions, 2 case scenarios, 2 questions. It's gonna go back and forth to each team. So we start. Let's start. We have a 4-year-old with a prior history of reactive airway is transferred to your side due to respiratory distress. The child has had 3 days of rhinorrhea, cough, and low-grade fever. On admission, the patient weight is 16 kg, heart rate is 140, respiratory rate is around 40, and SATs around 90. X-ray showed hyperinflation, area of atelectasis, and possible small pneumomediastinum. So the question is going to be in the chat. If you forget it or you want to check something, Dr. Milan will try to post it there. And let's direct the first question to the high flow nasal cannula team. So for Dr. Christophe, Dr. Andreas, if this child was going to be put on high flow, how would you support your decision doing so? What would be the setting of high flow and evidence for it? Why do you think high flow would be superior to NIV?
Okay, so thank you very much, Abdurrahman. And I think this is a wonderful question because it's the one we had this morning when we received a child. And this is a question we have, I think, every day in our PQ, and it's not simple to answer. I guess that this we don't have a lot of. Maybe we can go back to the case. We are dealing with a patient with asthmatic crisis, and we don't have a lot of data, but we can guess that the child is mildly severe, and I would say that it is a little bit severe because the respiratory rate there is a little bit high. 40 is high, and I think it's important for us to start to thinking about this because he's starting to breathe rapidly. That means that he will have some difficulty to release the volume of his lung, and he will probably have a dynamic autoinflation, which is quite good because it will be, and we saw this with the X-ray, that he had hyperinflation, which is good because the compliance of the thorax, is going to decrease at this time, and it will help him during the expiration. So this is quite good, but the patient will have to pay for it because at the end of the expiration, the pressure in the lung, as you know, with the autopip is going to be quite high, between 8 and 10 centimeters of water. And so he will have to struggle to fight this autopip. And this is where I think as IC intensivist, we are going to help the child because obviously with asthmatic patient, the treatment is corticotherapy and bronchodilatator, okay? And pressure support is just here to help him. And we are not going to treat the patient with this. So we'll have to choose something to improve the comfort of the patient and something to decrease the exhaustion of the patient. So this is the main point. And I'm quite sure that the NIV team is going to explain you why it's possible to do it with NIV. But I think that with the high flow, we can do a lot of things, great things with the high flow. And the first of all is that we are going to treat the patient with the heated and humidified gas, which is great because when we are comparing this gas with the fresh and dry gas, it's going to decrease the bronchoconstriction of the patient. And as you know, with the high flow, we are able to fight against the resistance of the patient, and we are going to decrease the work of breathing of the patient during the inspiration. So that's great. Another point, during the expiration, we are going to wash very effectively the oropharynx, so we are going to remove the CO2. That's great. And we are going to create a small PEEP. But I know that Marti is going to laugh at me because it's small PEEP, and if we want to make a PEEP, we need CPAP. Obviously, I'm right with, and I am okay with Marti. But what is very, very important, and the difference with the NIV is that the high flow is very, very, very comfortable. Okay, and with this patient, with 4 years old, is going to be very afraid of everything. Is going to arrive in my PQ. It's a wonderful PQ, but very stressful. And when I'm going to apply a mask on his face, it's going to be scared. So I think it's much better to use the small prongs in the nose. It's going to be very important for his comfort. It's going to be, the anxiety is going to decrease. It's very important with the asthma. We've got some data about this, comparing the use of high flow and low flow. Recently, Robin Pouillot released his data with a very important randomized control study with 300 patients, 140 against 140, and showed that the intubation, not the failure rate was much better with the high flow, 7% and 30%. To my knowledge, there is no randomized control study comparing high flow and NIV. But maybe Andreas is going to say more things regarding this aspect. There is just a retrospective paper done by Alex Modesto in Spain, which is the retrospective thing. So it's difficult to have some clear conclusion about this. So I think that high flow definitively is a very, very good option at the beginning there. And after we will have to see if it's all right. Andreas, I'm quite sure that you will have a lot of things to add to this.
Andreas?
We have to hear Andreas because he's a smart guy in my team, okay?
Sorry, yeah, I've been muted.
You, Andreas.
No, again, thank you very much for having the opportunity to talk about, high flow versus non-invasive ventilation. And I actually don't like when we talk about what's better, because it is different. So if you can go to slide 5, that's just the next slide. One up, yep. Yeah. So what do you have to keep in mind, and that's where we are stuck quite often, that we only think about ICU. However, the patient's journey starts most likely in the emergency department, and therefore the skill, the knowledge and experience of the emergency department that this patient is admitted, it depends where it is. So do you have an ICU on site? Yes, no. Do I need to transfer a patient? Yes, no. So these are all factors that are playing in the decision to place a patient on high flow. And if you can go to the next slide, the real questions, what do you need to ask? What is the physiological effect of non-invasive ventilation compared to high flow? And in this table, you can see that the dead space washout is probably one of the important factors, but it can or will deliver high flow some increase in the FRC. And if you look at the next slide, when you look at the work of breathing, and if we compare CPAP directly to high flow, and I'm not talking here ideally about BiPAP, so on the inspiratory phase to support the breathing. So if people use just only the CPAP alone, there will be certainly positive or more benefit for the patient, because you actually assist the inhalation where CPAP doesn't assist at all. So in this child, if presenting to ED, I'm not sure how many hospitals would initiate non-invasive ventilation comfortable without, let's say, an impact or having support by the ICU. So it really depends where you are. Shall we go to the next question?
Yeah, so Dr. Anders, what would be the setting of high flow, and is there an evidence for the choice of setting that's going to be the child put on?
So yeah, if you can go to slide number 9. Yeah. These flows that we have used in the Paris 2 study are a direct result of looking at the peak inspiratory flow per age group or per weight. And the reason why we have chosen these different flow rates is because they match the inspiratory demand. If you can run the video, just clicking on it. Yeah, here you can see me underwater breathing. For 10 minutes I was underwater, so I didn't drown, but I'm certainly matching my inspiratory demand because I had a complete washout of the upper airway. And if you look into the next slide, please, there was just a recent study comparing CPAP with the helmet. And as you can see here, different parameters such as esophageal pressure time product, so that's the amplitude times the respiratory rate. You can see that high flow is not as effective with the impact on lung mechanics. So we need to be aware of that there's limitations as well, where and how you use high flow, and particularly as well that high flow CPAP or non-invasive ventilation certainly has a more accurate pressure delivery and numbers that we can see on a screen. And that's the biggest problem with the high flow. We just look at this flow. Will it be enough? Should I give more? We still don't know. We still don't know what exactly the ideal rate is.
So what do you think high flow would be superior to NIV?
To answer that question, I actually don't like to answer the question because I don't think there's a superiority of any of these two modalities. We need really to think what's best based on physiology for a particular patient, and what is the trajectory, the possible trajectory of where this patient ends up. That means we need to know where the patient has been admitted. Have you got access to an intensive care unit? Yes, no. And it really, the patient journey through the hospital should come in your mind in the decision making where you're heading to. And hence, I wouldn't call non-invasive ventilation superior to high flow. It all depends on what you're looking at. So when Ram published his study, they were looking at the length of respiratory support that the patient experienced during their stay. And what they did, they were randomizing children who need some form of respiratory support, and then they measured the length of liberation from either CPAP or high flow. Can I have the next slide, please? So in this trial, as you can see, the high flow patients stayed longer in the ICU. However, for us as intensivists, we are much more interested in looking how many were intubated in the group of non-invasive ventilation versus high flow. And you can see that the intubation proportion is similar in both groups. You can also see, interestingly, once they are on CPAP in Ram's study, they stayed longer in the hospital. And if you look at the next slide, he plotted the different diagnostic groups. And I just want to highlight that when they performed that trial, that there are not many cardiac patients, obviously, because they're most likely coming from theater. So they are not going the same direction as the respiratory cases.
Thank you.
For this child, certainly I'm 100% sure in any emergency department, if it's indicated, most of the emergency department, at least what I have seen, they will initiate high flow on the regular 2 liters per kilogram. Again, that rationale is based on the maximal inspiratory flow the patient can deliver.
Thank you. Thank you, High Flow team. So now it's shifting towards the NIV team. I don't think Christophe was personal with Marti, but that was clearly directed to Marti regarding if this child was going to be put in NIV, you need to defend the NIV, Marti. Manu, what would be the setting of NIV and any evidence for it? And why do you think NIV should be superior for that patient compared to high flow? Nothing personal. That's Christophe and Andreas' opinion regarding that patient. Now it's yours.
Thanks, Abdul Rahman. And again, Andreas and Christophe, I have learned a great deal from you, interacting with you all, reading your papers over the years. And I take Christophe's point on comfort very well, that yes, HFNC is comfortable. We do not dispute it, but we dispute is whether comfort is the right metric when the physiology is failing. And again, thanks to Andreas for explaining part of the physiology. And in this patient, I think clearly what is very evident is that this kid has a viral triggered reactive airway disease and an obstructive physiology. So in these cases, what we need is an external PEEP to counteract the intrinsic PEEP and reducing the inspiratory threshold load. Similarly, I think from what Christophe correctly said, this child has a respiratory rate of 40, SATs of around 90%. So obviously he seems to be working hard. And this is where I think an NIV as IPAP, EPAP, and the delta P directly unloads the diaphragm and augments the tidal volume. But I think the big game changer for me is the air leak. So any child who has an air leak on a HFNC clearly has got some sort of rupture. And basically, what my concern is, if I would be putting this kid at 2 liters per kilo per minute, assume this kid, we are giving around 30 or 40 liters per minute. I don't know what the airway pressures are. It can be unpredictable. And in this situation, I would prefer a CPAP or a BiPAP where the pressure is limited and there is a clear pop-off. So I know what are my limits. And I think, and again, looking at few papers from the emergency medicine setup, especially the beer study, etc., what they looked at in patients with reactive airway disease in an emergency medicine department, CPAP and BiPAP was found to be more superior. And again, I think as Andreas has already explained the physiology, we can just scroll through the sites and then I can just answer the question on what settings you would use. So you could go to the 4th slide, please. And again, I think this is an algorithm what we use for initiating any sort of non-invasive ventilation. And again, what's most important is to have a right interface for adequate pressurization, to choose the right ventilator, and then you can either start with CPAP or bi-level ventilation, but the important thing is start with low settings of an IPAP, EPAP, and keep a difference, delta P of 4, between your IPAP and EPAP, and gradually stand on the bedside, gradually increase the pressures, because yes, you want to gradually make the patient feel comfortable on these settings while his lungs are adequately pressurized. And then you look for improvement in the saturations, decrease in the work of breathing, and improvement in the vital parameters. With this, I hand over to Marti for the third part of the question.
Yeah, I think that we can agree absolutely that with this clinical scenario, this patient can be placed on high flow nasal cannula outside of pediatric intensive care. So the idea is this is a mild to moderate patient with a wheezing disease. So I see that there is no room for this patient in the PICU, and especially starting with non-invasive ventilation. But if the patient is slightly more sick, let's say a respiratory rate of 50 and more air trapping, so the physiology is supporting that we are going to unload the inspiratory muscles, and we are going to reach earlier a reduced respiratory rate with bilevel than CPAP, and with CPAP with high flow nasal cannula. So I mean that what the idea with the dynamic hyperinflation is there and is severe, I think that we should run for the first shot should be bilevel. However, as I said, looking at this patient that is a very mild one, I agree that can be outside of the intensive care and can benefit from all the comfort and all the treatment that you explained very well about high flow nasal cannula. Thank you.
Thank you, Dr. Marti. So you agree with Dr. Andreas regarding starting the high flow for the patient during his stay in the ER until it needs shift to the ICU. So let's go to the second question. Second question is one of the things that I think every intensivist have had that question in his mind regarding what are your considerations when escalating respiratory support and deciding what supports to use for post-extubation. So if you're going to extubate the child, should I put him in high flow or should I put him in NIV? And is there evidence supporting high flow versus NIV to prevent extubation failure? So the question towards the NIV team, Dr. Marti, what do you think?
So after extubation, so it has been already shown that it's going to reduce the CPAP, the winning time. So that's what the evidence is saying. No, it's not a big number. So it probably is not clinically relevant. But the idea is that most of the patients after extubation for many years just received low flow oxygen without many other problems. I think that we should focus on which patients we are talking about, as what is the failure mechanism? Is hypoxemic, is hypercapnic, is there respiratory muscular fatiguing? So all these questions should favor the use of non-invasive ventilation or the use of just low flow oxygen. It means that we won't have strong evidence that there is the need for high flow nasal cannula. So, Manu, do you want to add something?
I agree with you, Marti.
So you agree that the choice of it depends on case by case rather than it's generalized that the patient with post-extubation he needs to go to the NIV rather than to go to high flow.
Again, I think Abdul Rahman, again, what you can do is you can always divide these patients into low risk and high risk patients. So if it's a low risk patient, if you're concerned, you could consider high flow. But if it's a high risk patient, which would be somebody who's been intubated, ventilated for more than 7 days, or a neuromuscular patient, these patients, I think there's a high risk of extubation failure. So even when you look at RAM's analysis of the step down, I think the majority of the patients who required non-invasive ventilations were the patients who had some sort of neuromuscular condition or who were sick, especially on the basis of a higher SF ratios, lower SF ratios on the initial presentation.
Excellent. So the question now to the high flow nasal cannula team. So what are your considerations when escalating respiratory support, deciding what support to use for post-extubation? And is there evidence supporting high flow versus NIV? So the question to Dr. Christophe and Dr. Andreas.
Andreas, you want to start? Maybe?
Yeah, okay. Look, there's plenty of studies out there, and after reading that many studies, I'm still not sure that we confidently can say one modality is above the other. What RAM showed here in this slide, when they performed the ABC trials, where they randomized them either to high flow or CPAP, and in all fairness, the study looked as a primary outcome in the length of stay, because that was so-called client or consumer driven. For us as intensivists, we are more likely, or we want to look at preventing intubation. That's our main game that we're playing. And as you can see in the next slide, is that the intubation proportion was similar in the CPAP versus high flow. And that's quite a remarkable finding in the sense that that was always the question, do you prolong the misery till the patient gets the tube? And with RAM study, we certainly can say when it gets to sorry, that's the wrong slide. Can you go up to slide number 12? Sorry, didn't pay attention. No, 12. Yes, okay. As when you look at, I'm just looking at the wrong slide. If we go to slide number 12, no, that's further down.
Okay.
Up. Yeah.
Wrong direction.
Yeah, you're going the wrong direction.
Ah.
No, you're still, sorry, it's really at the beginning of the slideshow.
So you need to go further up. Yeah. For the first case. Yeah.
Yeah.
This is the
So
one. Yeah.
yeah, that's the one. And now if you can go to the next slide, where you can see the highlighted time that they were in the ICU. No difference when you want to prevent escalation, either from high flow or non-invasive. And what Ram just showed in this study, that when a patient presents with an increased work of breathing and oxygen requirement in your intensive care unit, that neither of the modalities are going to win this race. I mean, it's still at the discretion of the clinician when they look after it. You know, it's more or less what you take from the menu in a restaurant, your favorite meal, and then you either choose non-invasive or high flow. But the literature doesn't necessarily strongly suggest that the initial respiratory support should be non-invasive ventilation. You actually can use both.
So just to summarize what the high flow team is saying, that if you put him in NIV, you just give him misery of the NIV and let him tolerate it. And eventually that's not going to change if you put him in high flow versus NIV for the reintubation possibility.
Yeah, I think that we can add that in this case scenario, we are able to choose, between CPAP and high flow. This is, I think, very important to consider that it's different than the previous one, because before we to start NIV or high flow is different according to the place we are. There, the patient was intubated, so we have to choose something, and the question is more they were I think more accurate there. And well, I like very much the paper from Ram, of course, and I like the comment from Steven Stein, who was just saying that maybe the patient who were staying a little bit longer with the high flow was maybe because he was more comfortable with the high flow. It was a funny way to see this,
Yeah. So the patient likes the high flow, he stay on it longer than we put him in
Yeah, it was a
NIV.
question of 6 hours, so I think it's not very relevant as an outcome.
Yeah. Okay, so back to case scenarios. So the question is going to be direct. So, sorry, Dr.
Yeah, no,
Andreas,
that's
you need to add something.
okay. Yeah.
So let's assume that you have an 8-year-old boy with a history of cold, cough, and fever for 5 days. On the first day of admission, his respiratory rate was 38, saturation 88 on room air, and it reached 100 on just 2 liters of nasal bronze. His respiratory rate is, his heart rate is around 108, and blood pressure is 108/52. So his chest X-ray as shown here. So the question directed toward the high flow team. Why would this patient be a good candidate for high flow, and what are the contraindications to put him on high flow? Would 2 liters versus 3 liters be differ in prognosis and the choice of this thing? And what are the red flags for escalating supports and ending the high flow?
Christophe, do you want to go?
Yes,
So
thank you for this case, because something that we are seeing quite often in the emergency department. I think that we can see this patient every day, and it's very interesting and very tricky and story, because we got a common cough, and the patient with a pneumonia, and he requires a little bit of oxygen, not too much. The saturation is 88. That means if we are considering the saturation of a FiO2, it will be around 40, something like this. So we are not in RDS design, but this is the pneumonia. So we know that it can be worse in a few hours or few days. So we have to consider this patient very carefully. And what are we going to choose? I don't know if we are going to propose high flow or low flow or NIV. It's difficult to say, according to me, but if we have to propose something, I think it would be interesting to start with the high flow. Why? Is because we will be able to have a good titration of the oxygenation, because when we are providing low flow oxygen, we are providing nothing, it's 88, and we are providing 2 liters, it's 100% of saturation. That means it's too much. So maybe it will be 1.5. We don't know exactly about what the FiO2 is. Maybe 25, maybe 28. And what I want, like as an intensivist, is to know when the patient is going to getting worse, and if we've got a way to assess the FiO2 correctly, I think it would be good to change the way we are going to treat this patient. And with the high flow, we will be sure about the FiO2. So, and if the FiO2 is going, I think, up 40%, for instance, I think that we are going in the red zone of the management of this patient. But we have to be clear with the patient who are taking care of this patient, The good part with the high flow is always the same thing. We are providing a wonderful oxygenation, a very good humidification of the secretions. The physiotherapists are going to love us a lot. So small thing like this, and I'm not sure that I would choose the NIV at this point. We loved, all of us, Mohammed Chisti, of course, who is using the CPAP there, but I'm not sure that I will consider CPAP at this point. What I love very much with Mohammed Chisti is the way that it's possible to use CPAP everywhere, but I'm not sure that I will do it there. And when we are taking the ABC trial, there are some pneumonia inside, and we saw that it's not inferior to use high flow and NIV, but even there, in this part, I'm not sure that I will take the high flow. And maybe, Andreas, we have a different opinion, and I will be very happy to hear it.
Yes. Can we go quickly back to slide number 6, if possible? We talked about it.
from the first question, right?
Yeah. So, well, yeah, that's good.
That's it.
The next. Yeah. The question is, when this patient present, what's the underlying pathophysiology? And you mentioned it's likely a reactive airway. So it's not just the respiratory support. We need to look at how do we inhale salbutamol or any other drugs, and how it's going to be delivered into the lungs. And if you look at what the factors that support the patient in a different way, if you compare nasal high flow to CPAP or non-invasive ventilation. And I think one of the most important benefit from high flow is actually the washing out of the dead space as well. Not that non-invasive ventilation can do that, but with a mask, you're just adding additional dead space, and particularly in very young infants, this can actually become critical, that they have quite an inefficient ventilation. And so, in my view, first-line treatment here is certainly not CPAP or non-invasive. First, give it a go with high flow, and it will be much better tolerated by the patients on top of it.
And just
So
about the flow, I think that was
yeah,
the question of the flow, and you were proposing 2 or 3 liters per minute, but I think for this patient it could be and it probably is too much, And what we have seen with another population is the bronchiolitis. I know it's different, and this patient is 8 years old, but what we wanted to compare 2 liters with 2 liters. And we thought that there was no difference in terms of efficacy. But what was, I think, most important part is that the patient with 3 liters were not very comfortable, and compared to 2 liters. So I think that, and Andreas explained this very well just before, he showed that we just have to match the inspiratory demand of the patient. Probably no more than this. And what is difficult to have is the peak inspiratory flow for the small child, but for the old one, for 8 years old, we know, and probably between 25 and 30 liters per minute, it should be enough for this one.
and what do you think regarding there is a flag that you need to stop the high flow and that's it, we need to escalate things?
Well, one of Andreas is going to answer better, but I think that the thing that we are afraid of is I think RDS patient. We don't want to miss the RDS patient, and if the patient is not improving, but I think that it will be my key message at the end. We have to consider the dynamic aspect of the patient. We can choose whatever you want, we don't care, but you have to see if the FiO2 is increasing, if the respiratory rate is increasing, and everything like this. And if the FiO2 is increasing and above 40%, for instance, you will have to consider the RDS, and so you will have to follow the algorithm of the RDS patient. I think it will be the red flag of high flow, but it will be the same with NIV, I guess.
Yeah, if I can add to this, in the Paris trials, we compared obviously standard oxygen with high flow. I think the best parameter that you can easily measure is your simple respiratory rate and heart rate. When these kids are febrile, it's not very helpful if you rely on heart rate only to judge how sick the patient is, because salbutamol, for instance, makes everyone sick, and the tolerance and drug delivery is so much easier, depending again where you are within the hospital. But you probably would agree with us that in the normal emergency department, either in a tertiary children's hospital or a metropolitan or even a rural hospital, I doubt that they're going to have many staff who are comfortable using non-invasive ventilation.
Thank you, Dr. Ines. Thank you, Dr. Christophe. So now to move to
if you can go up quickly. No, next one. I think this is important for people to realize. So if someone observe, and that's part of our medicine that we need to do. So we see the patient on admission, and then we see the patient maybe 15 or 20 minutes later again in the emergency department. And you want to see an effect of your treatment provided. And in the Paris 2 trial, for instance, we said anything like an FiO2 greater than 40, you should start getting concerned. or if the respiratory or heart rate are not settling as well, or even are reduced, then you need to start again about de-escalation. In the Children's Hospital here in Brisbane, the pediatricians are happily to use 3 liters per kilogram in the pediatric wards. So once you started it in ED, you need to think, where do they end up? Is it the ward or is it your intensive care unit? And be mindful that the majority of children with lung disease or acute lung disease, they're not presenting to the tertiary or quaternity hospital. They're somewhere out in the suburbs. They are somewhere in a different town. And you have to consider that as well when you plan and execute your management of your patients.
Excellent. Well said, Dr. Andreas. So that's to summarize that it's mentioned to say that he's not saying to Dr. Marti and Manu that their mask is causing more CO2 retention, more dead space, but it does. In reality, you have to be very cautious in choosing your appropriate interface. And add to that, the high flow 2 to 3 there's not much difference, except the 3 is going to cause more irritability, and you have to be really cautious when going. And you see that is vitals, it doesn't come down, then you have to have an alarm sign that, okay, I need to escalate now. So that's thank you from the high flow nasal cannula team. So we go to the NIV team. Why would this patient be a good candidate for NIV, and what are the contraindications to put him on NIV? And would pressure support versus pressure control differ in this prognosis and the choice of the setting? And what are the red flags to escalate the same thing from NIV? That's it, we need to intubate. So the question goes to Dr. Marti and Dr. Manu.
Thank you, Abdul Rahman. And again, thanks, Christophe and Andreas. And I completely agree with you that the therapy depends on where you are, what setup you are. Because I completely agree that most patients don't end up coming straight away to a tertiary setup. And from, if I recollect this case, it was an 8-year-old with fever, cough, tachypnea, and I think on 2 liters of oxygen. So this could as well be a consolidation or a pneumonia. And again, in these sort of patients where you have consolidation with a shunt physiology, I think it's fair to start with.
Sorry, Dr. Manu, you're disconnecting.
I can continue if you, meanwhile, he's
Sure.
coming back.
Sure, you can
So,
take it, Dr. Marti.
first of all, I would say that the scenario, it's clear a patient that we never seen in a PQ in
38,
Spain. So this patient is in the
38.
general ward. Sorry,
So
Manu, it was just I jump in because your voice was
You're
off.
disconnected.
Sorry.
Okay. So yeah, so I think he is tachypnic. So again, when you look at it, 8-year-old child who's awake, alert, he's a good child. He's a good one to communicate about the discomfort of the mask. So if he is requiring more than 40% FiO2, I think he's a good candidate because you can talk to him. He's hemodynamically stable. So again, he's another patient who's safe to try on NIV. And again, when you look at it, day 4, day 5 of the illness, and if he's still unwell, you're concerned. Will his persisting work of breathing result in self-inflicted lung injury? Can I just have the next slide, please? So again,
Sure.
Christophe mentioned about Mohammed Chisti's trial, and again, it's a beautiful trial which is reflecting the practice in most of the world, where you don't have all the therapies what we have. So they use bubble CPAP, and again, in his study, what he found was bubble CPAP was better than high flow, better than low flow. So again, I think in the patients on the CPAP therapy, in patients with pneumonia, the deaths were lower. Can we go to the next slide, please? And again, when you look at what Andreas was mentioning about the ARDS, and again, I think I welcome these changes which has been recommended by PALIC, and you can see you have the whole spectrum. You have the high flow, you have the BiPAP, you have the intubation. But I think what they say is you initiate a therapy, you closely monitor the patient, give them a 2 or 4 hours of trial, stratify where the patient is, use parameters like SF ratio, check what the SF ratio is. Is it below 270? Is it below 235? Is it below 150? And based on that, you can say, okay, if it's somebody with a SF ratio below 150, then we need to question, is this a patient whom we need to escalate straight to intubation? But again, in the mild to moderate, I think again the PALIC 2 consensus is you can start with high flow. If you think the SF is going down, you can escalate to NIV. And again, in a time limited manner, I think if the heart rate, respiratory rate, and the FiO2 is not coming down, then obviously this is the time where you escalate to the next level of therapy. Can we have the next slide, please?
Sure.
And again, I think what's important is you start NIV, but I think what we have learned over the last couple of decades working with the Spanish Intensive Care Society group is that you need a systematic approach to initiating NIV. And this is something which we designed, I think, long back in Stoke on using an Iceman algorithm. And I think it's all that you need is a structure so that you know what's the indication. Is it a type 1, type 2 respiratory failure? Can I just go to the next slide? You want to know what are the contraindications, because not all patients can be initiated on NIV. So if someone is having a low GCS, is having an active upper GI bleed or imminent cardiorespiratory arrest, hemodynamic instability or craniofacial trauma, or an SF ratio is below 150, these are not candidates for NIV. So I think, you need to wisely choose the patients whom you would initiate non-invasive ventilation. With this, I hand over to Dr. Marti.
Yes, I think that the cutoff of the SF ratio, what we are using, the good window for NIV patients is with SF ratio below 270, so below 300. The patient that we were talking about in this scenario is above 350. So it means it's clearly a patient that is not going to be in the PQ and is not going to be NIV. However, so some of these patients in low middle income countries, so that they don't have more resources, so and they cannot escalate to intubation. So it means that an early start on CPAP so makes sense if the SF ratio is clearly below the 300. I think especially below 270. So regarding the second question, talking about the pressure support or pressure control, basically most of the patients above 3 months, all the patients are capable to activate most of the ventilators in the market. So you are not experiencing asynchronous, inspiratory asynchrony. So it means they can be in pressure support mode or in ST mode, etc. So no need for that. What we are claiming or suggesting is for older, younger patients that are not strong and not capable to activate the inspiratory trigger, please go for T mode or for pressure control mode just to get more breaths, real breaths with bilevel support. Because if not, these missing efforts are going to be a great problem for the patient and can even deteriorate earlier the patient and promote the need for intubation. If we can move to the next slide. So as you can see here, it's the pathway that we are using for all the patients that we are, and can be 2 to 3 months that most of the ventilators are working. So we can decide whatever the option we want, but especially when we are facing these asynchronous, think about the pressure control mode. Next one. Okay. So I think that about the red flags, so it was explained earlier by Manu, and I think that it's important just to early identify those pneumonia patients that become an ARDS patient. So thanks to PALIC consensus, now we can use the SF ratio for an early diagnosis. We are more sensitive, but especially after 6 hours of the early diagnosis, we can really confirm if the patient is an ARDS or not. And we should know that mild to moderate ARDS patients can work reasonably well on NIV with a 75 success rate. However, if you have an ARDS that is severe one. So you have only 1 to 6 hours trial. After that, you are not recruiting the lung, you are improving clearly the situation of your patients. That's clear a red flag for this patient that is actually a severe patient with a chances of failure higher than 50%. So, and it haven't been said or published in pediatrics increasing mortality because probably we are intubating all these patients in the first 12 hours. We're not waiting more than 24 hours on NIV. That's what's happened in adults, showing an increased mortality. We should be cautious. So especially in those patients that are really going down to this SF ratio monitoring and increasing work of breathing, because these pneumonia patients, they can be easily ARDS patients. Thank you.
So regarding
Can I
yes,
add some
sure, Andreas.
comment in regard of what people use? So we looked at, I think it was more than 250,000 ICU admissions in Australia and New Zealand. And we observed that over a time period of 12 years. And what we have seen is basically that the same proportion of children, if they are on CPAP or non-invasive ventilation, the same number of patients receiving in the intensive care unit. And based just on these figures, we know that non-invasive ventilation is quite heavily used. However, if it's a matter of logistics, the patient is in the emergency department or on the general ward, you may, if you're successful, and there are many papers out there talking about prevention from intubation, and the Paris trials went even one step further, where we said that we compare standard oxygen versus high flow and looked at relevant outcomes as well in the length of stay. And what the Paris 2 trial showed in children less than 5 years old, on average, they stayed longer in the hospital. And the more important factor there, how many did get intubated? And it's staggering. Out of the 6,800 patients that we reviewed, our intubation proportion, so you have to think about the following. There's a patient coming in with respiratory troubles, and then you want to deliver oxygen. And in the PICCS, it's sort of in Australia and New Zealand 1-to-1. So there's no preference or strong argument in most of the cases. I think it's just what is more convenient. In my setting, for instance, if we have them on high flow admitted to ICU, and we're actually happening how they develop, we can discharge them, within 6 hours to the ward where they continue the high flow treatment. And that's not an option you have in most places. I know there's hospitals, they use non-invasive ventilation as well on the general ward, but you need to think, again, thinking about where is the patient going? What's the patient flow? What type of respiratory support are you feeling comfortable? Have you good nurses that are looking after a face mask? It's a huge skill and experience. So you need to take all these factors into account.
Thank you, Dr. Andrea. So one of the most important things is also to put it in the equation is what Dr. Andrea is trying to say is that you need to think about your manpower and their capability. If the nurses can handle the high flow, you can shift them to the floor. So to answer regarding the NIV question, so the pressure support that it can generate, and as long as he can trigger and generate, you will put him in a pressure support. Since he is 8 years old, red flags, both teams agree that you should be really, really cautious in pushing the patient. I remember Dr. Marti is telling always be courageous, but not too crazy. and don't push numbers beyond. Like I always remember, I tell the people, don't push the child because children don't like to be pushed hard. And once you see those numbers dropping, you need to intubate the patient. So the last question or scenario is, given a superior tolerance and ease of use in children, should high flow be the preferred first line non-invasive over a pediatric patient? And does it offer a safe and more practical standard of care than NIV in mild moderate bronchiolitis? So can NIV be initiated and maintained out of the PICU? So the question goes to Dr. Marti and Dr. Manu. What do you think?
I think because we have our partners are really an excellent and awesome researchers. So we have many of the answers in the field are published by Christophe or by Andreas. So this comes from Paris study because they were really performing this high flow oxygen therapy in infants with bronchiolitis outside of the intensive care. So that also there is a paper for Keoprotes. So there are several randomized control trials showing that it's safe and it can be done out of the intensive care. So and because on these papers they accepted the crossover, it seems that high flow is not reducing the PICU admissions. But if in real life we don't have high flow nasal cannula, I would say that that you have increased number of patients because they're using only low flow oxygen. So my message is that I agree that even though the lecture of this paper says that we because they accepted the crossover, but actually looking at those patients, if they couldn't accept that crossover, probably then they would increase the PICU admissions. So the message is that that in our point of view, so for bronchiolitis, for mild moderate, we are using as a rescue treatment in the general flow, because also Keoprotes paper showed that it's not and there is another paper that is showing that it's not cost effective. So let's go to the next slide. So we can see this the paper of Keoprotes, so showing that that we are rescuing patients out of the intensive care with high flow nasal cannula. So that's the good position of that. So it means that the idea is that if it's available, it can be used. But let's see what happens about the use of CPAP out of the intensive care. Let's go to the next one. So this one is about cost effectiveness. That's important to say that because we know the pendulum that people at the beginning is no, don't use it, and then it's using for everybody. And that's important to say that that at the end it's a good rescue treatment in some places in the world, that especially if they don't have really higher resources, that it can be discussed use the CPAP or not. But I think the idea is that it's not for all the very mild are not. So that's for mild moderate patients failing on low flow oxygen. Let's go to the next one. That we know that there is increase of this high flow nasal cannula. It's a significant increase, and is increase in the cost. And the important thing is to say that for me, in my experience, so that 15 years ago, that patients were admitted for intubation criteria in the PICU, we had at least 6 to 7 respiratory arrests in the general ward before getting to the PICU, because the patient was with just low flow. When we started to use high flow nasal cannula and we instituted this high flow nasal criteria, since then it's almost 1 or 0 patients per season having respiratory arrest in the general flow. So it means that even though we can say that we are not reducing significantly our PICU admissions, less than 5%, so we are using it and we are increasing the safety in the general ward. Let's go to the next one. So the idea is, I agree in the general word as a rescue, but not as first line in the PICU. Let's go to the next one. So let's move. So
Okay.
let's see.
I
That's
think
important. Yes, please.
Yeah. So Manu, you need to jump in.
okay. So
What
I
do you
think the
think can
question
NIV be
was,
initiated
can NIV be initiated and maintained out of the ICU?
out of the
So I'll
ICU?
just go with the evidence and then tell you my view. So basically, in this survey on NIV practices in Europe, pretty old paper, but you can see this. Yes, it is used outside the ward, outside the ICUs, in the ward, emergency department, and the transport. Next slide, please. Again, similar paper showing that yes, it is being used in transport. Can we go to the next paper, please? Next one. And again, I think now this is a very old, what do you call, a project by the Pediatric Critical Care Society in UK. As you know, most of the world, we always have ICU bed crisis. And this is a time when Dr. Kevin Morris came up with this paper it's a white paper on high dependency care for children, time to move on. So what they were looking at was what patients can be safely managed outside the ICU. And this is the time when I got involved with NIV. Can we just go to the next slide, please? And you can see this is level 2 or HDU care. So this is level 2 critical care is HDU. And in this, you can see what the patients, what they mentioned, what can be used outside our acute non-invasive ventilation or LTV or care of tracheostomy. Next slide, please. And this is when I think we started working. How do we do this safely? The most important thing to do NIV safely outside the ICU in an HDU setup is that we have to train the staff. The most important people to train obviously are the nursing staff. And this is how I met Marti, Alberto, and subsequently Christophe and all. And we started running this acute non-invasive ventilation courses. Next slide. And I think, what, again, I'm coming back to is you can start NIV, but you need to have a structure. You need to have a clear criteria, which patients to select, which patients you would not put them on NIV, especially like Marti highlighted multiple times, the severe ARDS. Those are the patients who need intubation. So basically, NIV is not a indication for all patients. You need clear patient selection. Next slide, please. And again, we already mentioned about the Paris 1 and 2 trials. I'm not going to be mentioning, but you can see that the Paris 2 trial, again, it was the older patients, 1 to 5 years. And you can see that the patients on high flow, as Andreas had mentioned, I think the failure rates were higher. Is that right? In the patients, I think in those patients, they did better on the other therapies. Next slide, please. I think this you already explained. I'll just go to the next one, please. Yeah, I think that's for you, I think. Okay, I won't take over your slides. I'll stop over there.
So regarding Dr. Christophe, Andreas, regarding can high flow be initiated and maintained outside the PICU?
Scroll to the previous slide. I think that was Andreas' slide.
Yeah, no, the simple question is yes. When we performed the Paris 1 and the Paris 2 trials, we looked at the intensive care admissions and what is the proportion of these patients who are hypoxemic with increased work of breathing in the emergency department. So what we just recently done, and it's ready for submission, I'm just showing some data from our registry, where we measure actually the length of non-invasive respiratory support. So that's high flow CPAP or BiPAP. And so if we're looking at these patients, during the Paris 1 and during the Paris 2 trial, we had obviously missed patients, and we had patients who were critically ill that the clinician didn't want to enroll this kit into either the Paris 1 or Paris 2 trial. So you can see that we looked at quite a big number of patients, and now we can compare for the cohort from 1 year to 5 years. They were admitted to the general ward, most likely out of the 3,500 in Paris 2, and only 408 were in the end out of this big number of patients admitted to ICU, and very, very similar as well for the Paris 1 trial. Now, can you show me the next slide, please? What we discovered is actually a bigger problem than we anticipated. It's not the patient who dictates ICU admission. It is the question, have you got ICU on site? So in this table, we show the patients that needed ICU admission in Paris 1 and Paris 2 trial. But we looked at the hospitals that have no ICU and the hospitals that have access to ICU. And you can see that between the ICU at the hospital without any ICU, they have a much lower in total ICU admissions when there was no ICU that you can quickly tap in. So it's patient flow, availability, and our clinical impression that drives more the reasoning for either using non-invasive ventilation or CPAP. But the hospitals without any intensive care are performing better than the tertiary hospital, which is, in our view, quite remarkable. So it's not necessarily all the time which modality is superior to others. It is really as well important what you're doing in your institution, how you handle these patients.
Do you think that those hospitals that didn't have ICU were pushing their nurses and manpower were exposed to more critical patients that made them able to handle those patients rather than to refer them to the ICU?
Yeah, it's completely correct. It all depends on what your service can deliver. So in a service environment, particularly in the UK, where CPAP has been on the wards for decades almost, but other health services just don't have the skill to look after a patient on a mask. Hence, it's much easier to use high flow. It is just simpler and easier as well to train nurses with it. So it's an important factor that you need to consider within your own environment, that you have a mutual understanding what the ED physicians are doing and why did they put someone on high flow. Did the patient actually need high flow? And as I've shown before in the other slide, it all depends as well where your hospital is. If you have to transfer them out, then obviously the decisions that you're going to make are completely different compared if you just move your patient into the
Andreas, just a
intensive care
thought.
unit.
Do you think in any of this, I think audio?
Yeah, we can hear you, Manu. Hello?
Yeah. And just I think that we can add that it's very important to consider the dynamic. I just repeat what I said before, the dynamic aspect of the patient, because it's not the support by itself, because the nurses are able to handle the high flow or the NIV. It's not a problem. The parents are doing this at home very well. But the condition of the patient is the more critical part, that we have to look at the patient. We know that if they are going to fail, they are going to fail during the first hours. 2 hours, 6 hours, 12 hours, according to the study. If we have a place where it's possible to look after those patients for 6 hours, for instance, in the emergency department, if it's possible, after we will know if the patient is stable or not, and it will be possible to, according to the hospital, according to the ratio of the nurses per child, it will be possible to have something, I would say, original, you know.
I'm
But
just
the
being
dynamic
devil
aspect
advocate.
is critical.
Yeah, but my question to Dr. Christophe is, would pushing the child, for example, on high flow on the floor, and if he's borderline, you just keep pushing him with low monitor than in the ICU, that he might have a higher mortality, because there is, like, we know that the critical care monitoring is way far advanced than what's he gonna have in the floor. So would that affect his mortality rate?
Are you referring to HFNC compliancy? Because I think that's what happens, because you can be oxygenating well, but your
Yeah.
CO2 might be creeping up, your illness might be
Yes.
progressing. So you do
And we
get
don't,
complacent with HFNC, especially outside the ICU if the monitoring criteria are not strict.
And I think it's a very complicated question and a very accurate question, because we don't have the data in the literature, because we are doing this kind of thing at the end of the bronchiolitis season, just before the immunization program, because at the beginning of the outbreak, everything is correct, everything is okay. And at the end, we don't know where to put the child, and we are putting the child everywhere we can. And there is no clear for us. We are doing this actually. I guess that it's the same everywhere, and we don't have any death. But the problem with the bronchiolitis is that the death is very low by
Yeah.
hopefully.
Yeah. So the take-home
I can
messages.
make a comment here.
Sure.
Again, I'm relating this to these tables because these are the questions you need to ask yourself on top of what your service can deliver. Can you show me the next slide, please? So when you look at this 4-year-old, it is really, where can I initiate high flow? There's hospitals, they can't initiate high flow in the emergency department because they haven't taken that step yet. So it all depends where you are. And for high flow, you certainly need to meet the inspiratory demand. You remember my short video being on the water. And certainly we know that the high flow is better tolerated and or less invasive in that sense for the patient.
I think just go to the last slide, please.
Yeah.
So again, I think we just summarize. Just stop on the other slide, previous one, please. Previous slide. Yeah, I think this is where I think we were just summarizing. Again, I think Andreas has mentioned very well regarding where you initiate the therapies depends on the resources, what you have, the nursing resources, the medical resources, and the equipment. So again, like, I think depending on where we are, I think there are papers supporting each therapies what we can use. But I think what I use in real life or in practice is that if you just go to the last slide, please, Abdul Rahman, just last one, which is just a simple flow chart, which next one, next. The last slide, there's a, we had a, okay. So I don't think you have it. So it's okay.
Yeah.
I think I'll just send it to you and then you can share. No, I think not this. I think you can just go back to the take-home message, what Andrea said. I will just share the one, what I have.
So you think that the high flow is still, it does not generate beep, and once the time you need beep, it's really, you need to question, should I go for the high flow or not?
I'll just show you the last one, I think, which I had sent to you. Apologies, I think, if you didn't receive it.
Can I just make
So can you see
one
the
comment?
slide? And
just one comment is that what Christophe as well mentioned, it is really, really dependent on what your service can deliver with all the skill set around it. I think that's a much bigger driver. If you look at ICU admission, as I have shown you, that the proportion of patient admitted to ICU is not only disease related, it's probably more the logistics within your own hospital, as this is actually driving that patients get admitted. Or if you are a parent, you better avoid the tertiary hospital and go to one of the metropolitan, then you know your child is less likely to be admitted to an intensive care, where someone may even attempt to intubate if they're unhappy. So starting high flow at the beginning in any major hospital makes sense to me, because as mentioned before, the trajectory where the patient goes is an important factor then that you take in as well. And it's not high flow versus non-invasive ventilation. It really depends where you are and what's the underlying physiology. So in this 4-year-old who didn't seem too sick to myself, I would have gone first just to standard oxygen and then escalating to high flow in the general ward, which is possible. I don't think that we have yet a good patient selection, or I don't think that we have criteria that helps the clinician. Really, this is an ICU patient, probably needs non-invasive ventilation. We still don't have these robust criteria where we can actually, teach what to use and where to use.
Thank you, Dr. Andreas. Can you see the slide, Dr. Manu?
Yep.
Yeah.
So,
can you see?
yeah.
Can you hear me? Yeah.
Yeah.
I think what we were thinking was, I think what's more important is that you need to try to match the intervention to the physiology. So if you have a child with respiratory distress or failure, like we have mentioned, if the primary issue is a hypoxemia, you can manage. And if you think that the patient only needs a flow, you have two options. You can either go with a low flow or a high flow. But if you think that, okay, I need is pressure, then probably high flow is an option, but not the best option. Probably the one what you can give a measured pressures would be a CPAP or a BiPAP. And this would classically be a patient with type 1 respiratory failure. And if you think your main issue seems to be hypercapnia, and these are the patients where pressure would be preferable. And so again, coming back to these therapies, all of these are complementary therapies. So like in a classical mild to moderate bronchiolitis, again, high flow has got a very good role and from the clinical evidence. But again, if you got somebody with hypercapnia or neuromuscular or post-extubation patient or type 2 respiratory failure, again, you need pressure. So hence NIV would be a better therapy. And again, I think the most important thing is match the therapy to the physiology and not to the interface. Over to my esteemed colleagues for their comments.
Thank you, Dr. Manu. Dr. Marti, any last words?
No, I think that we have covered very nicely the different point of views, and I think that we are at the end at the same page. So saying that okay, that that physiology matters, but logistics even matters more. So it depends if you have transport team, you have PICCU on site or not. It's going to influence a lot in your decisions. Whatever, with all the knowledge we try to share is at least try to do to make better decisions and not spend money in ineffective treatments. So I always try to say, from the beginning, the patient has severe apnea and is close to a respiratory arrest, please go directly for intubation. No playful with NIV, even less with CPAP or high flow nasal cannula. It means if the patient has a clear contraindications, even you have the choice and you have the material, the stuff, don't use it. So make wise decisions.
No, we lost Marty.
Yeah. Dr.
Can
Marti.
I add just what's going to be published hopefully soon is when we look at
So that means that with those patients, we have to know all of that and apply all these ideas.
Thank you, Dr. Marti. Sorry, Andreas, you want to add something?
Marty just dropped out, so we probably have missed half of your message, Marty. So my comment is the following. We have data out of around 5,000 patients that were either placed on standard oxygen or high flow on the strict criteria. And as I showed you before in that table, that if you don't have an ICU on site, it's much less likely you have to transfer because they can actually sit on them and nurse them so they don't need to be transferred. But one more important aspect is that we have out of these 5,000 patients, only 0.3% in Paris 2 type patients, so 1 to 5. And in the Paris 2, we had only 0.4% roughly patients who are intubated, which is remarkable. And the same is happening for bronchiolitis, where we have 0.65% of the patients only intubated. So it's ridiculous to watch these numbers. No one these days, or hardly these days, use now invasive mechanical ventilation because we're starting to master the use of high flow or a BiPAP. So if you're on the winning street, which looks like here in Australia and New Zealand, where high flow is the initial therapy in ED because they don't have the skill and knowledge of non-invasive ventilation. So these patients graduating to an ICU, it is more likely that the clinician thinks, I need to do something. I can't just keep with the same treatment as in the emergency. And therefore, we see as well, probably a lot of patients who actually don't need high flow at all. They just need supplemental oxygen. And these days, everyone is very scared of just even mild work of breathing scene. And everyone starts to panic and says, this patient is too sick for a general ward. But in the Paris 1 and Paris 2, we have shown, no, you can look after them on a ward. So it's feasible.
Thank you, Dr. Andreas. With that, being your host, I've been honored to raise the debate between you guys. It's like now I can leave you with my colleagues, Dr. Milan, Dr. Michael, Dr. Georgie, to take the question. I think there's a plenty of questions running in the chat, so I'll leave the mic to them. The mic all yours.
Dr. Christophe, I'll direct the first one to you. What is the evidence around high flow nasal cannula being an inspiratory aid?
I think that when we are considering the resistance in the nasopharynx and here you can see that when we are providing a very high flow, you are going to overcome those resistance, and this is, I think, specifically true with the child. And the smaller the child is, and the most important the effect will be, because we are going to decrease this about 50% of resistance here. And when we are providing the high flow, we are going to decrease this resistance, and we are going to improve the respiratory. There are several work, and we have done one of them showing that we were able to decrease the work of breathing. And maybe one of the best one was done by Robinder Kemanit's team, showing that he was able to decrease the work of breathing by 20% or 30% according to the flow. So it's something true.
Great. Dr. Andreas, what is the evidence that high flow improves FRC in children who breathe with their mouth open?
So we did, now you're getting me in a question that I can't even remember anymore what we published. But we looked at the work of breathing measured using measuring the electrical activity of the diaphragm, so the NAVA probe. And what we could show that the strength or the effort that the diaphragm has to do is lower compared to just standard oxygen. So we clearly could demonstrate in bronchiolitic infants, and as well then in our control group, these were the cardiac patients. We didn't see any difference in the sense of efficacy compared to CPAP, but certainly the physiological argument why and how it is actually supporting can only be measured because we don't have a measurement device, just we can't put a flow meter. So that's why we measured the electrical diaphragm, and it certainly decreases the work of breathing significantly.
Dr. Manu, do you practice crossover from high flow to nasal to NIV or the reverse if either modality fails?
So basically, in our hospital setup, am I muted? No, yes, I think. In our hospital setup, we have clear limits for how much of high flow can be used on the floor. So up to 2 liters per kilo and up to 40% FiO2 can be done on the floor. These patients who fail, if they come to the ICU, we put them on CPAP. And usually the most common reason for these patients for deterioration is collapses. And a lot of times we find that these infants, once they have 6 to 8 hours of NIV of CPAP, they improve significantly. And some of the older infants who are initiated on CPAP, I think they're uncomfortable. And when they fail, we have used the learning from Christophe's paper and tried them on high flow, and it does work. So yes, I think it's a real life situation which is reflected in the paper, and I think the crossover does work in practice.
And Dr. Marti, if you practice in a setting where resources are limited and you have to choose between investing in either high flow or CPAP, which one would you choose? Try not to be too biased.
No, that's very important question, because we have different papers saying different things. So if you are in Bangladesh, Dr. Chistis is saying okay, CPAP, a handmade CPAP is much better than high flow nasal cannula. On the other side, you look at a paper published in Ghana that doing CPAP without monitoring, without doctor supervising, increase mortality. So it's really, oh my God, so I don't want to increase the mortality. In some places, just starting CPAP without any kind of monitoring, and having the possibility to escalate to intensive care can be dangerous. So in those places, perhaps the literature is supporting just stay doing high flow is the best for most of the patients. So on the other side, it was also a low middle income country, but just in a hospital setting with a proper monitoring, it's saying that the contrary, that okay, you are reducing mortality just using CPAP. So it means that don't spend your money putting first your patients in high flow, and if those who are failing, putting them on CPAP. That's what we are doing, Manu or me, in my hospital. So we are using the high flow nasal cannula as a rescue in the general ward. We are still using the CPAP as a rescue. So 50% of the patients failing on high flow nasal cannula remain in the general ward. So during the winter season, with a slightly increase of the ratio of nurse-patient ratio. So, and we are rescuing more than almost 60% of the patients remain on the general floor with CPAP. So, but we are talking about, okay, a hospital in Barcelona and with a PICU inside. So, or in a region like Catalonia, that even if you don't have a PICU inside, you have a transport team very well trained on NIV that can transfer the patient safely. So nowadays, people are starting NIV in the emergency room, even they don't have PICU, because they know that in 1 hour, 1 hour and a half, they will have the transport team that will safely transport these patients to a PICU. So it means, again, so it's going to depend on what it's available on your side. So I think that in our position, in our country, with our wellness, so we are just, but talking inside the PICU, I think the first line should be CPAP or bilevel. Talking about, as we have been talking all the time, and starting from the beginning in the emergency department or in the general ward, I think that there is room for the high flow network.
So if a particular hospital only had money to buy one or the other, where would you put your coins?
Right. I think
So,
having taught with Michael on his courses, when you're talking about these hospitals where you buy only, you've got limited funds. I've had the fortune of teaching with Michael where there are hospitals where there is no electricity. So then the question is, which of these devices will work? There are hospitals where there is no oxygen. So I think the best expert among all of us who can shed knowledge on this, I think, is Michael, because through his critical care and resource limited settings, he's been teaching in all parts of Africa. And I think he knows the region, what resources are there and what they can afford. Right, Michael? You might want to use this couple of minutes to just give your insight.
Sure. Manu, thank you. I think, though, that our commenters have already pointed out that often it's really not a choice. I think that there are already limitations placed, but you make very definitely point out the difference between having oxygen and having electricity, because obviously if you have oxygen, you can provide flow, right? And so that can allow you to do, for example, artisanal CPAP, right? If you don't have electricity, then your limitations are great because you can't use any of the conventional non-invasive machines. And so I think more often than not, it's how to optimize the resources you have, and sort of the basic being that sort of, the duality of having oxygen, having flow. And I think that that's often the limitation. I know that artisanal CPAP is kind of universally used, and I agree that there are obviously some pitfalls using that in different settings, but it's in my experience, it's been extremely helpful in many settings. But I don't think that most places have the opportunity of selecting, and I think picking one versus the other. My feeling about high flow is that the parts and having sterile water, having clean circuits, etc., having the wide range of cannulas that's required can impose a hardship. But I'm sorry, Manu, I don't profess an expertise in this, just an interested observer. But I do think that a lot of the times it's really determined by
I know that, yeah.
Let me do a short comment. So that we, San Juan de Dios Hospital has a brother hospital in Africa, and has a maternity with patients, with premature patients. So, and when we decided to help, so we bought 2 CPAP machines. And so we that's what we did. So, and we are really offering for small prematures, so the CPAP machine, that is neonatology. It's another scenario. But I think that in a hospital that has a neonatal ward, a small one, very simple, that was our choice. I'm not saying that is the absolute truth, is the best solution, but it's what we did. And people working there are very happy after it's the BCPAP Pumani, very simple device, and it's working very, very nicely for many years.
I just want to add that Sorry. I had the opportunity to work in different countries like this, and all the time when I was visiting a hospital, there was always in the back a lot of old ventilators, unused ventilators, and it was possible to bring them back. Of course, it was difficult to have a proper trigger or everything, but we don't care because when we were using them just as CPAP, it was very easy. So I know that I was defending the high flow, but in those hospitals, it was quite easy to have a good CPAP. Even with a very cheap interface and something like this. It was not perfect, of course, but it was possible to have I think a good CPAP. Maybe not in IV with 2 level, but CPAP at least it was quite easy. The problem with the high flow in this country, because try to find one in Mauritania, it was the problem of the tubes and to reuse the tube because it was very expensive, but to reuse the tube in Mauritania, it was very difficult because to wash them, to dry them, it was very, very complicated actually, much more than the use of the CPAP.
Georgina, can I make we haven't talked, I think the CPAP versus high flow at the beginning of the patient's journey through the hospital, I don't think that we have yet a really convincing data. For instance, the ABC first showed no difference if you use CPAP or nasal high flow. But Abdul, if you can go to slide 28. So I will start in between. So what we did, we looked at 12 years worth of registry data, and we compared in this study children on CPAP and children on high flow post-extubation. And the reason why we've done that study, because we've seen a complete overuse of high flow post-extubation. And so we wanted to find out how do they actually perform when you extubate them. You remember the ABC trial, the step down in the ABC trial showed that when you place the same patient either on high flow or non-invasive ventilation, they stay longer on the high flow compared to CPAP. However, what we have shown, can you go up again? Yeah. So we did a propensity match comparison between patients that either had high flow post-extubation versus non-invasive ventilation. And so we did find 1,400 episodes. So we matched really twin and looked at the relevant outcomes. RAM's study has shown that, as I mentioned earlier, if you place them on high flow, in general, they stay longer in ICU. Can I have the next slide, please? Then when you look at the extubation failure rate between the two groups, so this should be published soon in the PCCM, you see that the number of extubation failures on CPAP is equivalent to the high flow group post-extubation. So your risk to reintubate is around 8% with either modality. If you show me the next slide, please. Where it comes to the crook, we did find the length of respiratory support post-extubation was significantly shorter if you place them on high flow. So just remember, you wanted some respiratory support after extubation, and your choice is CPAP or high flow. Both are equivalent in the reintubation proportion. However, if you look at the NSPIC data registry, they stay post-extubation much shorter than the ones on CPAP or non-invasive. And I think this is due to the fact, again, that patients can be discharged to the ward on high flow from ICU once they are better. So that speaks again that it's a shorter stay after extubation for these children who are on high flow, which is just a matter of costs, but not necessarily in the end a matter of the disease severity, etc., etc. Again, we showed that too many kids get placed, for instance, post-extubation on high flow. They don't need it. In my experience, it was like you turn around after extubation, you didn't mention high flow, and the next time you walk past that bed, the patient is on high flow because someone just wants to use it. And I think that's where one of the biggest problem is, that we still don't have good, clear criteria who should actually receive what, either high flow or a CPAP. We still, in all honesty, we don't know.
Well, thanks, Andreas. There's some good thoughts there for people to consider. Another question from the chat, Dr. Christophe, 2 liters per kilo is the suggested flow rate to start on high flow. Is there any indications on guidance of what FiO2 to start on?
Regarding 2 liters per kilogram, it's very simple to keep in mind, but it's not always true, as we said. We were considering 2 liters per minute. It's for the bronchiolitis, for the severe bronchiolitis. At the beginning, we did Andreas speak at the beginning about the peak inspiratory flow. That means that we have to reach the maximum flow, of an inspiration. And we were measuring it with bronchiolitis because we didn't have any data. It was around 1.7 liters per minute and per kilogram. And it's the reason why that we are using around 2 liters per minute. And I mentioned before the very nice paper from Humidified and his team showing that the work of breathing was minimal when we were reaching around 1.5, between 1.5 and 2 liters per minute and per kilogram. That seems to be okay. Regarding the FiO2, it's not the problem of the high flow, it's the problem of the target. What are we going to use? And I think it's according to the disease, in New Zealand, and they wrote a very nice guideline regarding the bronchiolitis last year, and they say that for the bronchiolitis they need, I remember it was below 6 weeks, it should be between 90 and 95, I think, something like this. And when it's less than 6 months, it's between 90 and 92%, something like this. And according to the RDS, it will be 88 to 94. So it's different from the high flow. The target of the FiO2 will be according to the disease.
Great.
I don't know if I was clear or not.
Yes, yeah, I think so, yeah.
You're kind. But the thing is that with the high flow, we can be very precise regarding the titration of the oxygenation.
Michael, I'll hand over to you.
The important factor as well as a learning point, if you don't match the inspiratory flow, you entrain room air to match the minute, or if you don't deliver the minute volume via your nasal prongs in the high flow system, the patient has to entrap or trap air from outside. And in the times where we actually weaned the flows, I'm talking about 15 years or more ago, it was a common practice as well to wean the flows. And what happened quite often is that you said, turn the flow back to 1 liter, and then, or even lower, and then they see the patient struggling. And the reason why the patient, particularly newborns or infants, is you block their nose and they can't breathe with the nasal prongs in there. And a lot of I can't wean my patient is because I can't wean the flow because the patient starts to struggle. No, you just take off the high flow, give just a little bit of oxygen if it's required, and you can put it on again if the patient really, without obstruction, is having trouble with his work of breathing. So
Yeah.
in all fairness, it is a real clinical judgment and the right way to use high flow.
Mm.
There was something more with when we were performing the Tramontan 2 study, we were comparing two different flow. And it was very funny to see that the group who was under 3 liters per minute and per kilogram was staying one more day in the PQ compared to the one with 2 liters. And one day in the PQ is something very important, And this was probably because of the weaning process, as Andreas described, the people coming from 3 to 2 to 1, and it was, I guess, not good for the baby and not good for the economy too.
Mm. Well, thank you, gentlemen. It's been a fantastic debate tonight. A big thank you to our esteemed speakers, again, Doctors Christophe, Andreas, Manu, and Marti, for sharing your extensive expertise and practical takeaways. A reminder that this episode and all past sessions of the Pediatric Critical Care series are available for free on the WFPICCS YouTube channel. Please remember to complete the 1-minute survey when you leave the session. The feedback is extremely valuable for us to guide future sessions. And you can also register now for our next webinar that'll be on the 16th of July, titled Opening the Lung Without Bursting It. Our expert speaker, Dr. Rabinda Kamani, will break down the practical science behind PEEP, recruitment manoeuvres and prone positioning. Our guest speaker, Dr. Shekhar Venkatraman, will also add his expertise to this discussion. And don't forget about the WFPICCS World Congress in September, early bird registration until the 30th of June. Thanks again, gentlemen. It was a great debate, and we will see you all next month.